Session is Dr. Archana Dandapani, and she is going to talk on conventional topical versus dropless therapy following phacoemulsification.
Good morning, everyone. I'm Dr. Archana Dandapani, and my study is on conventional topical versus dropless therapy following phacoemulsification. I have no financial interest. And in introduction, we know cataract surgery is one of the most commonly performed surgery worldwide, and it has evolved over a period of time, and so does the type of intraocular lens. But the postoperative care remains the same. So what were the drawbacks of topical therapy? Poor compliance comes the first, and dependency, self-administration problems, cost factor, efficacy issues, and safety issues. Our aim of the study is to evaluate the safety and functional outcome of dropless cataract surgery compared to the conventional topical therapy. And the outcomes assessed were best corrected visual acuity, intraocular pressure, anterior chamber inflammation, postoperative complication, and patient satisfaction. It was a randomized controlled trial conducted from June 2022 to June 2024 with a sample size of 700 eyes. They were divided into two groups, Group A, dropless therapy, and Group B, topical therapy, and each group consists of 350 eyes. Inclusion criteria: patient with aged 18 years or older with visually significant and cataract and normal fundus examination were included, and patient with mature cataract, history of uveitis, glaucoma, previous ocular surgeries, retinal disorders, intraoperative complication like PCR were excluded. And all patients underwent phacoemulsification, and Group A, at the end of phacoemulsification, 0.1 ml of intracameral moxifloxacin and 0.1 ml of subconjunctival triamcinolone were given, and no medications were given post-operatively. And in Group B, routine post-operative, topical, antibiotic, steroid, and NSAIDs were given. Both groups underwent post-operative assessment at day 1, 7, 30, and 60. All the parameters were assessed by the same two experienced ophthalmologists for all patients in all visits. Patient satisfaction was assessed through a feedback questionnaire where patients were asked to grade the level of satisfaction with their treatment protocols, 5 being the highest and 1 being the lowest. In case of score less than 3, reason for dissatisfaction was evaluated. In results, mean age, sex distribution, and comorbidities between the two groups were similar, and the preoperative IOP, grade of cataract, phacoemulsification time were similar between the two groups. In postoperative intraocular pressure in Group A in day 1 was found to be like more than 10% of patients had IOP more than 26 mmHg with mean value of 25.39, which was significantly higher compared to the Group B, but it was similar between two groups in the consecutive visits. Best corrected visual acuity was similar between the two groups in all visits, and anterior chamber inflammation was assessed by slit lamp examination, which was found to be similar between the two groups by day 30, and endothelial cell was also comparable between the groups. On patient satisfaction, Group A, 96% of patients reported highly satisfied, highlighting the convenience and ease of protocol, and even highly recommended to the others. Whereas in Group B, only 56 patients experienced similar satisfaction, and reason for it being the complexity of managing multiple postoperative medication, being dependent on others till the recovery, and stinging sensation and discomfort on installation of the drops. None of the patient developed endophthalmitis in the postoperative period in both groups. Subconjunctival hemorrhage was noted in 15 eyes in Group A during intraoperative subconjunctival injection of triamcinolone, and two groups in Group A had persistently high IOP more than 30 mmHg in postoperative day 7, where they started on anti-glaucoma medication. And 12 eyes in the Group A had breakthrough inflammation for which they were treated with topical NSAIDs and cycloplegics, and all of them resolved by 6 weeks. And the incidence of postoperative cystoid macular edema was slightly higher in the Group A, but although there was no statistical significance between the groups, and they were treated with topical steroids and NSAIDs, and only one eye in the Group A required an intravitreal dexamethasone for non-resolving cystoid macular edema. And the effective cost of topical therapy was Rs 900 per person, and dropless therapy was 60 per person. There were multiple studies were published which was comparing the dropless therapy with the conventional topical therapy, and they have used dexamethasone implant, triamcinolone, and different route of administration like intracanalicular insert or in transzonular injection, and all concluded that dropless therapy is not inferior to the conventional topical therapy. And I conclude that our findings support the Dropless protocol as a viable and patient-friendly alternative to conventional therapy, particularly in population where the compliance with topical regimes may be challenging, and future research with extended follow-up and larger multi-center trial is recommended to validate these findings and assess long-term outcomes. Thank you.
So thank you. A very interesting study. I don't think anybody of us have used this thing, but if the results are so good, and I don't think there is any harm in trying that. So how many patients did you do in this whole study? In
Sir,
which you did?
433 patients, but total 700 eyes. Some patients received Dropless in both eyes.
Okay.
Actually, similar studies have been done even with intracameral triamcinolone. The problem is you are giving steroids which cannot be withdrawn. So in those rare cases, in case you get infection, there is end off. What do you do then? There is no way to pull that steroid back.
Yes.
That is the major disadvantage. Otherwise, of course, the patient is going to be happier.
Because let's suppose the patient has a steroid-induced glaucoma or something. Then what you do?
Sir, actually, we gave subconjunctival triamcinolone, so we could see the depot in the patient, and we could assess the presence over the time also. So, two patients only had the IOP more than 30 mmHg in POD7, for which they were started on anti-glaucoma medication like beta blocker or alpha agonist. But by 6 weeks, all patients were found to be within normal. On stopping the anti-glaucoma medication, their IOP was maintained below the 21 mmHg.
That's true, but some patients who are really very, very steroid dependent, they have very, very high, it may be less than 2% or something like that, but then it's very difficult to treat those patients when you have injected. But otherwise, it's a very wonderful study.
Thank you.